Hello, everyone around the world. Thank you for joining the TBPPM webinar series today. We're really pleased that we are back with a very important topic today, where we are going to be talking about strategic purchasing and price setting. During this COVID pandemic, we have seen many interruptions in health services around the world, and the TB services are no less seeing interruptions everywhere. It's even more important these days to find ways of continuing services on ways that we are normally not used to do, including contracting the private sector, contracting the informal sector, or many ways to bring services online to serve people that are suffering of different diseases, including tuberculosis. This is an issue that is really important for us to learn more about, and we are very pleased that we have an excellent panel today to bring you experiences from the Worldbank and colleagues from the Worldbank who will be speaking to us. I will be introducing Ronald Mutasa, who is the health specialist in the global nutrition and population part of the Worldbank, and he's leading the TB control part of the Worldbank's activities. And he has a lot of experience in working in India and in Asia and in Africa in general in the Worldbank. He will be introducing all the speakers today, and he will be giving some comments overall. We have 3 presentations. The overall webinar will be 1.5 hours long. We will be recording the webinar, and we are currently live streaming on YouTube. You will be able to use the Q&A in our directly on our Zoom here for any questions or comments, or if you have any clarifications, please write them down in the Q&A at any time. We'll be trying to take them either immediately after the presentation if there's a clarification, or at the end of this session where we will be having time to take questions and answers. We are very happy to see that we have so many people already joined, and please feel free to also use the live stream on YouTube. With that, I would like to ask Ronald to start us off and start introducing our esteemed speakers.
Thank you, Petra. Good evening, colleagues. Good afternoon and a very good morning to those who are in the Americas region. As Petra mentioned, I have the privilege of introducing a very distinguished panel of colleagues I've been working with on a very, very important topic on health financing. So the first part is that I just wanted to mention that for those of us who have been working in the TB world, today's topic takes us slightly outside of our comfort zone, or rather sort of like our day-to-day nitty-gritties, into sort of like the strategic big picture on how do we finance healthcare, and how, more importantly, how do we finance TB and COVID related services. So I'll mention 2 points and then we'll go to the panel. Number 1 is that there is growing awareness that health financing is not simply about raising money. So that's very clear. And number 2 is that raising sufficient money is an imperative, but is not enough on its own. There's a whole question around how the efficiency of spending of that money, how do we achieve outcomes, and how do we really ensure that we're achieving value for money. Many of you, I think, have been exposed to the dialogue on health financing, have mostly been exposed to the revenue generation aspect. But as you all know, there are 3 important functions: revenue generation, there's the pooling part, and then there's the purchasing. So today's panelists are basically going to be focusing more on the purchasing function, and within that, we will also be focusing specifically on what is known as strategic purchasing. I'll leave it to the panelists to take us through the conceptual aspects of it, the global experiences, and then the specific experiences from India, as well as very, very exciting experiences from China. And then we will switch over to Guy, who will basically moderate the discussion. So to kick it off, we have our colleague, Owen Smith, and I will be introducing each panelist as they come on to speak. So I'll start with Owen Smith, who is a senior health economist in the World Bank, and has been working on health financing across the world, mostly in Europe and Central Asia, as well as in South Asia more recently. And Owen is also leading very, very interesting work on health financing related reforms in India and other parts of the world. He has also authored a lot of papers that are looking at beyond the COVID-19 pandemic, what are sort of like the most important big ticket item reforms that the health sector really has to be focusing on to achieve. And prior to joining the World Bank, Owen worked as an economist at the Ministry of Finance in Canada. So he brings government experience as well as global experience. And Owen will basically take us through the conceptual parts as well as the global experiences and some of the important lessons on strategic purchasing. So Owen, if you are ready, you can load your presentation and then you can kick it off. Thank you.
Thank you, Ronald, and good morning, good afternoon, good evening to everyone. And first of all, many thanks to the organizers for giving us the opportunity to present. Can I just confirm that my slides are visible?
Yes, we can see your slides, Owen. Great.
Okay. So thank you. My job is to give just a brief introduction to strategic purchasing. What is this all about, and what are some of the tools available for countries and programs looking to move towards strategic purchasing? I won't say very much about tuberculosis itself, but I think it will serve as a useful background for some of the presentations that are to follow. So just to provide a little bit of context, this is a WHO sort of conceptual framework where it links the health systems on the left-hand side, whether it's health financing or stewardship and governance or service delivery, with some of the intermediate objectives and final goals of universal health coverage. So purchasing is only one part of this big picture, but an important one, and as we'll see, there's a lot of complexity inside that box of purchasing. So just to acknowledge it's part of a much larger context. Now to go a little bit deeper just on health financing, as Ronald said, the classic sort of conceptualization of health financing is to emphasize these three different areas. One is the resource mobilization, so that's raising enough revenues for health. The second is what we call risk pooling, so that's managing the revenues that were raised in order to share the risks which are inherent in the uncertainty of illness across different groups, between healthy and sick, between rich and poor, between young and old, and so forth. And then the third aspect is what we'll focus on today is once the revenues have been mobilized and the risks hopefully pooled well, then what do we do with these resources? And purchasing is really about assuring an allocation of the resources and provider payment itself. And all of these functions hopefully are being done in an efficient and equitable way. I think perhaps the best way to sort of begin a discussion of strategic purchasing is to say what's the opposite, what is not strategic purchasing. And I think in a lot of countries, although perhaps fewer and fewer, which is a good sign, governments construct public hospitals or clinics, they employ healthcare workers, they pay monthly salaries, they procure drugs that then get delivered to facilities. But the focus in all of these activities is really on the inputs. It's not on outputs or outcomes. But we don't really care about hospitals and doctors and drugs for their own sake. We care about them because they come together to deliver very important services. So the shift in talking about strategic purchasing is to talk more about what these inputs are actually doing and achieving. So the starting point before this transition is made is that often there's no robust information on individual consultations or individual admissions. The incentives for improving quality or improving efficiency are essentially very minimal or absent. The private sector is really not in the picture at all. And when you have a health system organized in this way, or a health financing system that's organized in this way, then the whole planning and implementation are very weakly linked to important questions such as what services do we really want to deliver, what do we want to achieve this year based on information drawn from what we did last year, and this is what countries are trying to move away from when they pursue strategic purchasing. The main functions of strategic purchasing, and sometimes these are formulated in slightly different ways, but I think generally there's a lot of overlap in different frameworks. So one is the specification of benefits, that is deciding what services do we want to buy. The second is contracting, deciding from whom are we buying these services, public sector, private sector, what level of facility, what characteristics. Provider payment, so that's deciding how to pay providers and how much. Financial management, which is just knowing how much money there is and how much money has already been spent. Sometimes this is overlooked or forgotten, but it's a very important aspect. And finally, and critically, the monitoring aspect of purchasing, which is knowing how exactly the money is being used. What are the services? What are the outcomes of those services? How much do they cost, and so forth. So again, to highlight this transition from what we sometimes call passive purchasing to active or strategic purchasing. Under the passive scenario, there's no explicit package that's been identified. It's really the focus is just on the inputs. Moving towards services that are clear and explicitly defined and adapted over time based on evidence. Under the passive scenario, resources are allocated based on some norms, like let's have one doctor for every 5,000 population or what have you. Moving towards payment systems that are based on cost evidence and designed to create incentives for quality. Moving from a situation with no or almost no selectivity of providers, just going with all government facilities and nothing more, to having more selective contracting with public and private providers based on the quality and the outcomes. Moving from a situation of little or no quality monitoring to constant quality improvement and rewards. From being a price and quality taker to a price and quality maker. So that means really using the authority of a purchasing agency to set the prices and establish what quality is demanded. And from a situation where there's very little monitoring and evaluation to having a very robust M&E system. So I think strategic purchasing, if we sort of boil it down to the essentials, I think of it as really matching tools and objectives. So this picture, I like it, has maybe 30 or 40 different tools. And I think when you think about strategic purchasing, when you really get down to it, there's at least as many such tools, probably twice as many that one could come up with. It's really a matter of developing those tools at the country or program level, understanding how they can be used and using the right tools for the right objectives. So what are those objectives? We're all familiar with these. I've put down 11, whether it's coverage, access, utilization, quality, patient satisfaction, and so on and so forth, including equity and the supply capacity and so forth. So these are the objectives that strategic purchasing is often looking at. And then there's a great many different tools that are available. So here I've organized them into 7 sort of broad buckets, whether it's the benefit package definition, and I'll go through each of these in a little bit more detail as much as time will allow in a moment. Provider payment, provider empanelment, the quality area, the IT system. IT really is a cross-cutting issue that underlies perhaps all of these, but I think it's worth just highlighting and elevating it to being a very broad category of tools in and of itself. There's fraud control, which is a very important aspect in many insurance systems. And then citizen empowerment, which I think sometimes is overlooked, but really from an accountability standpoint, it has great potential to contribute to the goals of strategic purchasing. So let me briefly run through these seven. Benefit package design is sort of a step-by-step process, taking evidence and data on burden of disease, clinical effectiveness, equity issues, and so forth, bringing that data to hopefully what should be a broad dialogue with stakeholders, which takes into consideration values, citizen voice, criteria, fiscal realities, and so forth, and then coming up with a decision-making process, including sort of the political aspects of it and considering implementation. And at the end of the day, having a very concrete list of, okay, what are the services we want to cover? What are the services we're not going to cover for whatever reason? And also preferably a mechanism for thinking about what next. In other words, how does this package evolve over time? So once the decision of what to buy is made, the question becomes who is going to provide these services, who will deliver. There's lots of strategic purchasing tools in the area of provider contracting. What are the criteria based on which providers will be contracted? Accreditation mechanisms, their infrastructure, their staffing, geographical considerations, and then getting down to the nuts and bolts of contracting, whether it's accountability mechanisms, tendering processes, PPPs, and so forth. I'm going through this very rapidly, I know, to make sure the other presenters have enough time, but I think this is just giving you an idea of the many, many tools that are available. Provider payment mechanisms. These are a sort of a list of 6 that you see here. They differ in the unit of payment, whether it's for every service used or whether it's a lump sum or whether it's per day spent in hospital and so forth. They differ in their complexity and the incentives they create, and the implications that they have for efficiency and quality and so forth. Increasingly, some countries start to combine these together in different ways. And this table is to highlight that each of those 6 provider payment mechanisms have different incentives that they create, and being familiar with these incentives is important when strategic purchasing decisions and institutions and structures are developed. What do they mean for the incentive to have more patients, less patients, decrease the services provided, and so forth. Next, we have the quality improvement bucket. So there's accreditation, clinical protocols, of course, medical audits, using data analytics and provider feedback mechanisms to tell providers, on this indicator you rank, 10th out of 100 hospitals or 100th out of 1,000 facilities or so forth. Contracting for volume, pay for performance, so measuring quality and paying for it. It's not just about financial incentives, of course. There's a lot of evidence that peer review and professional recognition matter a lot as well. And then in some cases, deterrence, so penalties for malpractice. On fraud control, just to clarify what we mean by fraud, there's a whole spectrum here from fraud to abuse and waste and so forth. Fraud is really the extreme where there's a intentional breaking of rules, it's illegal. Abuse and waste are a little bit less egregious, and then errors, of course, are unintentional. And there's some examples there. In the table at the bottom, it's just highlighting that there's many different mechanisms that programs and countries do use to try to address fraud control. We divide it sometimes into prevention, detection, and deterrence. So prevention is trying to make sure it doesn't happen before the fact. Detection is identifying it when it does happen. And deterrence is what to do after the fact with those who have been identified as undertaking fraudulent behavior. So many tools again here. The IT system already, it's an element in how the functions I've already described are implemented, but again, it's useful to elevate and highlight it. It's just a critical tool for whether it's claims processing in an insurance system. It's a very important management tool. Standards for processing times or clinical protocols or quality measures and so forth can be hardwired into the system. It enables a lot of data analytics, whether it's quality improvement, adherence to protocols, fraud detection, efficiency, and so forth. And then you can, of course, create dashboards and monitoring and evaluation systems built on the IT system. So it's really a critical aspect of strategic purchasing. And then the last one I want to highlight, I think it's not commonly included sometimes in discussions of strategic purchasing, or it's maybe a bit of an afterthought. But I think there's a lot of scope for citizens, beneficiaries, patients to play a very important role in promoting accountability of providers and of the system as a whole. So there's the IEC channels that we're very familiar with, grievance redress mechanisms, whether it's hotlines, call centers, mediation services when required, engaging patient groups, upstream in sort of governance and board representation of an insurance system, benefit package design as well. Great role for citizen feedback, and legislation can play a useful role in ensuring patient rights. So that was a real whirlwind tour. I think I think the main takeaway message is that really strategic purchasing is making that transition away from a very passive focus on inputs and choosing and developing and institutionalizing the tools to achieve very explicit objectives. There are many, many tools available. I hope my whirlwind tour has conveyed that there's a lot of different options out there. Not to downplay or minimize how difficult it can be. Many tools are used to achieve a single objective. And of course, there's trade-offs between objectives. Provider payment may improve efficiency, but reduce quality and vice versa and so forth. Benefit package definition is not easy. So lots of areas to work on, and I think a lot of scope for strategic purchasing to contribute to objectives. So I'll leave it at that and pass it back to Petra or Ronald, and happy to take questions going forward. Thank you.
Thank you so much, Owen, for that overview presentation. And I'm sure during the question and answer, colleagues would come back to this. So we'll switch to the lessons and examples on strategic purchasing from India. And our colleague, Sheena Chhabra, who is a senior health specialist, has been leading very, very interesting work in India over the past few years. By way of introduction, Sheena is a senior health specialist with the Worldbank based in our New Delhi office. And she has a career that has spanned over 3 decades, worked a lot on universal health coverage, reproductive and maternal health, policy, strategy, as well as health financing related work. And on India, she's actually one of our key private sector focal points. She's been doing a lot of work around the private sector engagement. And prior to joining the Worldbank, she worked at USAID for several years, heading the health systems team there. And of course, she was in academia prior to that. So Sheena, why don't you take us through the lessons and experiences on strategic purchasing from India? Thanks, and over to you.
Good evening, good morning, depending on wherever you are. I just wanted to confirm that everybody can see my screen.
Yes, we can see your screen, Sheena.
Super. Okay. Thanks very much, Owen, for making my life very easy. What I'm going to be doing over the next 15 to 20 minutes is to share the early experiences that are emerging from Ayushman Bharat Pradhan Mantri Arogya Yojana, which is in short called PMJ, which is the world's largest government-funded health insurance scheme. And the Worldbank provides technical support to the National Health Agency and to PMJ. And in fact, this is a work which both Owen and I co-lead. What I'm going to do is to briefly talk about what is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and then I will share some of the experiences of strategic purchasing from PMJ. I was also asked to talk a little bit about the COVID-19 response of PMJ, and then I'll end with some of the key takeaways. In terms of PMJ, this is a scheme which is really targeted to the poorest 40% of the population, which is based on a socioeconomic census that was done, and 500 million people were identified based on that. And this is a federal scheme, and it's cashless, where a hospitalization-related coverage is provided to a household for about US $7,000 per annum. And under this scheme, it covers, there are specific benefit packages that have been developed, and I'll be talking a little bit more about that. And in terms of provision of services, they are provided by both a combination of public and private hospitals, and nearly half the hospitals impaneled in the scheme are private hospitals. And this is co-financed by the Government of India and the state governments. This scheme is usually, in terms of implemented by, in terms of, as I mentioned, if you look at the basic architecture, the Government of India provides a co-financing of the scheme. In partnerships with the state, the scheme is implemented. At the state level, there are two ways in which the scheme gets implemented. Either a specific trust is established under which is a special agency for implementing the schemes and looking at the claims management that is undertaken, or it is provided, it's contracted to a private insurer. But whether it is irrespective of a trust or an insurer that implements the scheme, that is really the strategic purchaser, then that gets into the claim management and the empanelment and the functions with both the public and the private hospitals. What's really very interesting and is in terms of whether we look at the trust or the SHA that implements the scheme at the state level, or the insurance company, which is contracted, implements the scheme at the state level.
Hello, Sheena. It looks like we've just lost you. I hope you can hear me.
It looks like we have some trouble with Sheena's connection. Her PowerPoint is still up, so I think she's still on the line. Maybe we can give her just a few seconds to see if she gets back on. Oh, it looks like we've lost Sheena.
Yeah, I think she's probably trying to reconnect so that maybe she has a better connection. Yeah.
Let's give her just a few seconds to see if she can get back on. Maybe in the meantime, I see that we have a question from Mayank Sharma from PATH. If there are any specific advantages in having separate purchasing authority, a purchasing provider split for strategic purchasing. Maybe, I don't know, Owen, would you want to take that call while we're waiting for Sheena to come back online?
Yes, sure. So that's a good question, Mayank. I think the answer would be, I think a purchaser provider split does help with strategic purchasing. It's not essential, but it does help to create sort of the arm's length relationship between the purchaser and the provider. So to put it another way, it's very unusual to see an advanced health system without a purchaser provider split. There are a few examples, but nearly all sort of high income advanced health systems would have the purchaser provider split. the caveat is that it's somewhat more complicated way of doing things, and I think in some settings in low-income countries it's easier to defer that agenda and go with the Ministry of Health and its facilities. But I think ultimately that transition is important, and it will make strategic purchasing more effective. But I won't say it's always and everywhere the immediate solution and immediate priority. But over the long term, it's I think a very important ingredient. I hope that answered sufficiently.
Thanks, Owen. That's great. I hope that also answers the question. And anyone who is listening in, please feel free to put your questions and answers in your questions in the Q&A, and you can also respond to each other's questions in the Q&A. I don't see Sheena online yet. Ronald, I'm wondering whether we should ask Dee to speak first, and then when Sheena comes back online, that we take her presentation after?
Sure, that sounds good, Petra. So Dee, why don't you load your presentation? So colleagues, we will switch temporarily from India, lessons from India to the lessons and examples, case study on China. So our colleague Dee Dong, who will be loading a presentation shortly, is a senior health economist in the World Bank. I actually have the privilege of working with Dee on the India program, and also Dee has a prior experience working on the China program. So I can say Dee has the distinction of working on two of the largest. Dee has the distinction of working on two of the world's largest TB programs. She has actually done a lot of TB program evaluation, economic evaluation and analysis. She's also done a lot of extensive work also on the health insurance scheme in India. She's also working on the Egypt program, as well as on the very large scale program in Saudi Arabia. So I always keep joking with Dee that she's one of the distinguished health economists who has sort of like a lot of experience on TB on the service delivery front lines. So Dee, it's over to you, and we'll be grateful if you could take us through the very interesting case study and lessons from the China program. Over to you, and thanks.
Thank you, Ronald, for the kind introduction. Actually, I think I saw Sheena connected again. I think it would be great if Sheena can just continue so that we don't interrupt her presentation. Sheena, are you connected? We hear you very briefly just now.
Yes, I am connected. Sorry, in terms of my
so maybe Dee, why don't you continue, and then Sheena will come back to you. You can load your presentation after Dee. And if you like, Petra can load your presentation. So Dee, maybe you can continue, and then we'll come back to Sheena.
Okay.
Okay.
Okay, so Sheena, I'll go first. Can you see my screen?
Yes, we can, Dee.
Okay, I'm going to put it on display mode. Okay, so good afternoon, good morning, and good evening, colleagues. So today I'm going to discuss some of the experiences of strategic purchasing for health services, including for TB service and COVID service in China. So I'm going to start with a brief overview of health financing and strategic purchasing in China, and then kind of try to put it in the context of why and how some of those vertical disease program financing can actually be integrated with the general health system financing. As I understand, some of the colleagues here work extensively on TB, and it is treated as a vertical program in some countries, but integrated into the general healthcare system better in the other countries. So I want to kind of discuss why it's integrated in China and how did that work. And then I'm going to share some specific examples on strategic purchasing of TB care and then COVID care. So first of all, I want to briefly introduce you to the healthcare delivery system in China. It kind of determines how the different types of services are paid for. So China healthcare system traditionally is a very hospital-centric system. There's over 34,000 hospitals that are providing inpatient care, specialist outpatient care, emergency care, etc. So 60% of the hospitals are private, but when looking at the beds, actually most of them are in the public sector. And in terms of the hospital admissions, most of those happen in the public sector, which is believed to have good quality and also lower cost compared to the private sector. So on the primary care and secondary care, there's over 1 million facilities. So they provide primary care as well as some specialist care and public health functions. And again, a lot of those are public and some are private. There's also 16,000 specialized public health facilities, and among those we have the CDC, the Center for Disease Control and Prevention, which are actually managing or coordinating some of the vertical programs, for instance the immunization program, the TB program, etc. So this kind of is the overview of the healthcare delivery system, and how are each types of care paid for and where strategic purchasing comes in is here. So I'll start from inpatient care. So for hospitalizations, a major funding source is the social health insurance program. So the social health insurance program in China kind of started around the 2000. So up to now, it's already 20 years of experience. And there are two major schemes which are covering the employees versus the residents. And for these two schemes adding up together, they cover over 95% of the population. And the reimbursement rate has gradually increased over time. So by now, for hospitalizations, around 60% of the total cost are paid for by the social health insurance. So how this works is that the insurance program, they have a explicit benefit package. So you may recall this from Owen's presentation, that there's a clearly defined package of what services or what medicines or what packages are actually eligible for reimbursement and what are not. So then in terms of the payment method, China for hospitalization are mostly using fee for service. So it basically means the insurance agency will pay the hospital based on how much is actually spent. For instance, for a patient, we'll look at what services are done, what medicines are prescribed, what diagnostic tests are done, and how much each of those costs, and adding those up. And the insurance will be able to pick out what those services are eligible for reimbursement, and then they'll calculate the total payment. So after the insurance pays, for the eligible part, there's also a out-of-pocket part, and those part will be paid by the patient's out-of-pocket. However, for those of you who know fee-for-service, there are actually a lot of challenges with it, in a way that if the hospital provide more service, they get more revenue. So it actually incentivized to deliver more services, and some of it might not be actually that necessary. So what we found is that China, for many conditions, actually have higher hospitalization rate compared to the other countries. For instance, a lot of the TB patients in China actually receive inpatient care. So this can be related to the incentive given to the hospital. And there are also other issues, for instance, the overuse of some of the second-line medicines or some of the liver protection drugs, which actually gives more financial burden to the patients. So a general trend now is try to use more innovative strategic purchasing methods to tackle some of those challenges and change the incentives given to the hospitals. For instance, case-based payment or DRGs are now being introduced. For instance, for one TB hospitalization, instead of paying based on the actual care provided, we might be able to pay for a fixed amount, no matter what has been, what services has been delivered. So if the hospital really deliver a lot of expensive services, but insurance still pays the fixed amount, that means the hospital has to bear the loss, which actually motivate them to really control their costs and do the necessary things and not to overtreat. Another popular method used in China is a global budget. So this is when the health insurance kind of want to set a cap to the payout in a certain year. So they may decide, I'm going to pay $2 million to a hospital maximum. If the hospital really spends more, I'm not going to pay additional. So it's a very nice way for them to kind of control their expenditure. But again, each of these methods have their pros and cons. So those are kind of some of the tools, the payment methods the insurance agencies use to purchase hospital services. So after health insurance reimburse some of it, the rest part are paid by the patients out of pocket. In addition to those, the government also provides some budgets to the public hospitals. For instance, some of the staff costs are covered and some of the infrastructure investment are covered from government budget. And there's also an increasing share of the private health insurance, which can cover hospitalizations. So on the outpatient care, including the specialist care and also primary care, a lot of it is paid by the patients out of pocket. And now increasingly the social health insurance program is expanding its coverage on the outpatient care. For instance, TB outpatient care is included under the insurance with a special TB package. And those facilities, those public facilities also receive government budgets. So it comes in the line item budget format in terms of the different chapters. And the last part are the public health functions. So for instance, the budget of the Center for Disease Control and Prevention for the TB program. So those are also covered by government budget. Some of the salaries come from the line item budget, and some of the programs, they have their program budget. For instance, the MDR TB program have a program-based budget each year. And also some of the public health functions, they come under a capitation-based payment. So the government actually identified 13 or 14 basic public health services, and then they package those together into this package and then pay by the population multiplied by a capitation amount, so that the doctors, some of the village doctors or the community doctors actually provide this whole range of 14 services for all the population in their catchment area. So basically, I kind of covered some of the TB payment examples, and you can see here the TB financing in China is really very well integrated into the general health system financing and payment pathways. So so I kind of want to give a historical perspective on why this decision is made. So historically, TB used to be a more vertical program approach in a way that there is a CDC department which handles only TB, and in some places we have those TB dispensaries, and they only manage TB, and they receive their budget, they treat the patients. But then later on, they realize actually so this model actually doesn't work that well. For instance, these TB dispensaries or CDC, they don't have hospital beds. So if a TB patient is really severe or has a lot of comorbidities or have liver damage, CDC are not able to handle those cases, and they have to transfer to hospitals. And that kind of introduces a lot of complexity in a way that how do you refer, how do you follow up, how do you manage. So later on, the decision is that let's move to a system where it's very well integrated into the general healthcare system, and just let the experts do it, and then we'll purchase service from them. So that's how the modern model comes in place. So the TB management control, they receive all levels of care from multiple types of providers, also making it very difficult to have a centralized program-based financing. So it kind of makes sense to integrate into some of the routine financing systems already exist. And the other kind of I would call it like an enabling condition is that there is a very strong existing social health insurance program which already covers over 95% of the population, and it covers a huge provider network, including the public as well as the private ones, and they already have the mechanism to send their medical records and bills to the insurance, and the insurance are able to transfer funds to them. So this is one of the really enabling environment. And also there are various strategic purchasing mechanisms the insurance agency already use, so why not also use it for infectious disease programs such as TB? And I think another key advantage is that from Owen's presentation, you may realize the health insurance agencies are actually doing a lot of the, they have a lot of tools, right? For instance, they know how to do output-based approach to ensure you get sufficient quantity of care delivered, and they also have different tools to kind of tackle some of the challenges. For instance, maybe in some regions they're under providing care, but if you pay kind of on a fee-for-service basis, more providers might be interested to come in to provide the service. Or in some places they might be over-prescribing medicines or over-prescribing some of the expensive diagnostic tests, and then you have tools to try to limit those behaviors. So they actually already have a set of tools which can be used to try to improve the provider performance and their behaviors. So those are very nice for vertical disease programs. And also they know how to manage the cost, the expenditures, and also contain the growth of expenditures, which is very important. And also there are some performance management and quality management mechanisms already there, and they kind of have some tools to improve efficiency. So I think those are really the expertise that the social health insurance program have, and it will be very nice to leverage on those expertise into infectious disease programs like TB. And also another benefit of this system we find is that the social health insurance program is very well incorporated with the social safety net in the sense that they provide medical assistance to the poor patients, and they are able to do the settlement all in one step. And we know a lot of the TB patients are actually the poor patients, and a lot of those in China are from the rural area. So instead of having them to get medical assistance separately, integrating with the social health insurance program actually helped them to just get all the assistance and the insurance reimbursement all at once, which make it very easy for them. And the other reason I think another advantage of the system is that it kind of also shifts some of the financial burden away from the government budgets, because the social health insurance program actually collect premiums and some of the contribution. So this way, some of the costs are actually shared by the enrollees themselves and not entirely by the government. So after talking about the reasons for shifting into this system, I want to give you more details on the TB care and financing system in China. So I think it's quite a unique model in a way that the TB clinical care are only done in hospitals. And also not all types of hospitals. So there are those TB designated hospitals. So usually is one public hospital selected from the county as the TB designated hospital, and they have some expertise in infectious disease treatment. So those hospitals, they are responsible for the diagnosis, the treatment of the TB patients, both inpatient and outpatient. And they also do the notification to the National Disease Surveillance System, the TB Health Information System, and also those doctors need to follow up with the patient. But those doctors, they can't really go out to supervise patients. So what happened is that they will refer those patients to some of the township or community or village doctors who will take the patient, do the patient supervision of medication, do home visit, and follow up with them so that they take their medications on time and do follow up consultations, and also try to track those patients in case they move from cities to cities. And the CDC is working as a coordination body who basically coordinates with all the other players in the system to make sure they do notification well. And CDC runs reports, and they also supervise the providers as well as the patients, and they also do some patients' home visits to look at the medication adherence, etc. So this is how the TB care are delivered, and it's a public dominated system centered around the TB designated hospitals. So how are those services paid? So the CDC, they receive government budget, and the TB designated hospitals for the medical part, they receive some government budget for the free TB treatment, which include the 2 free sputum tests, chest X-ray, 6 months of free first-line medicines. But they also receive funding from the social health insurance program for the other TB care not covered in the free TB regimen. So those are paid by fee for service. Basically, how much they spend, they will get paid. And in some places, there are pilots of case-based payment or DRGs, try to kind of standardize the treatment and also contain the expenditure. So this is actually giving incentives for the hospitals, because in some of the hospitals, they consider TB to be a very it's a not profitable specialty, right, compared to surgery or even general medicine. So actually, the motivation to treat TB is not that great if it's only the free treatment, right? So this way actually allows them to provide more services to those more complex TB cases, and also some of the inpatient cases. So for the TB public health part, some of the supervision, follow-up, etc. So those are receiving government budget under the basic public health service program, and there are a lot of regional variations on how they get paid. Some places they just bundle all the 14 services together and pay on a capitation basis, like say $2 per person. And there's like 2,000 population, they just get paid 4,000. And in some places, they really want to encourage the village doctors to supervise TB patients well, so they can do some case-based payment. For instance, for every single TB patient successfully completing treatment, they may get paid $2 added to their salary. So some regional variations of practice exist here. And then I want to introduce to you one of the strategic purchasing reforms. Is actually used as a tool to address some of the TB control challenges. So this was the China Ministry of Health and Gates Foundation innovative TB control model pilot, which has been ongoing since 2009. And in the phase 2 and phase 3 of the program, actually some interventions about innovative financing are introduced. So I'm going to kind of use this as an example to show how some of the strategic purchasing tools can actually be used to solve TB challenges. So at that time, some of the TB control challenges we see include a very high financial burden for the patients, particularly those poor patients, and also very high hospitalization rate for TB care. And we know, according to the clinical guidelines, most of the TB patients should be managed in an outpatient setting, but because back at that time, the inpatient care are covered by the insurance, whereas outpatient are not. So it kind of gave more incentive for patients to get hospitalized. And in order to tackle this challenge, the solution, the reform strategy is actually try to expand the coverage for outpatient care. So that those can be treated in outpatient setting, and also increase the reimbursement rate to reduce patients' financial burden. And another challenge we have seen is that some of the providers, they actually use some second-line medicines and a lot of liver protection medicines, which are having unclear clinical benefit, but it's really expensive. So in order to tackle this, the reform strategy is to implement a case-based payment for TB care. So no matter how this patient is get treated, the hospital will receive a fixed amount for each single TB case managed. So that is a way to really reduce some of the unnecessary care. And we also see this have some impact in terms of reducing the length of stay, reducing some of the unnecessary care, and also really encouraging more routine outpatient visits and more routine follow-up visits. And then I'm going to briefly touch upon financing for COVID-19. So since it started in end of December, so actually China has done pretty well in terms of COVID-19 control. So you can see from the graph, after April, the number of new cases are pretty small. So what I'm going to talk about is mostly the funding up to May. So as of May 31st, the COVID-19 response budget is around $23 billion US, which is approximately 1.1% of the GDP of China in 2019. And in terms of the funding sources, some of it comes from the social health insurance programs, and some comes from government budget, and also others like donations and some of the volunteers, etc. So the medical care, for the medical part for patients and also COVID-19 suspects, The insurance policy actually is tailored to provide coverage for COVID-19. So there are different steps. So first of all, the COVID-19 related inpatient treatment, they can still follow the standard insurance reimbursement policy, including the basic ones, the catastrophic insurance, and also the medical assistance program for the poor. And all those are paid on a fee-for-service basis. Pretty much, they will pay as much as the hospital spends. So the rationale here is that some of the COVID cases are really severe. For those in ICUs or those using some of the life support equipment like ECMO, the cost can go up to a few million. But in order for everybody to be able to get treatment, they decided to go with a fee-for-service basis, so that patients receive the care they needed. And there's some complexity for those migrant patients. Some of them get trapped in a different city, and the issue of cross-region settlement comes in here. So in that case, for a migrant patient, the bill will first be paid by the local health insurance bureau at the location of care, and then they will do the settlement with another regional health insurance bureau, so that the patient doesn't have to pay upfront. And after all those, the out-of-pocket portion is fully subsidized by government budget, so it will be zero cost to the patient. And most of this care actually happen in public hospitals, and also because private hospitals doesn't see this as a good business at that time. So some of the numbers, so among those hospital discharges, the average cost per case is around $3,000 US. So this doesn't actually reflect the total cost because they receive a lot of donations of equipment and also volunteers. So the actual cost might be higher. And for some of the very severe cases, the average cost per case is around $21,000 US. And the insurance, the social health insurance pays around 67% of all those medical costs. Yeah, and then for the testing, the public health, etc. So those are paid directly through government budget, and they were also able to mobilize some of the non-health sector resources and manpower, which are not actually counted in a budget. Yeah, so that's it, and happy to answer any questions. I'll stop sharing.
Thank you so much, Dee. So colleagues will quickly switch back to the India case study that Sheena was interrupted earlier because of the technical glitch. So Sheena, over to you.
Thank you very much, and I really apologize that for my connection. I hope everybody can see my screen.
Yes,
yes,
Sheena,
please go ahead.
Okay, great. So I think I was at the point where I was just sharing that in terms of there are three modes by which a state decides what should be their purchasing agency. Several states go in for a trust model. Some states go in for an insurance model, and few states have also gone for a mixed model where up till a certain threshold, about say 1 lakh rupees of coverage per family per year, they look at insurance. And since very few claims actually, the coverage goes beyond that amount then they look at, in terms of reimbursement by the trust model. And there is no magic bullet in terms of whether a trust model is better or an insurance model is better. There are pros and cons, and states have to really choose from that. The advantage of having an insurance company is that, the insurer, the state really shifts the spending of the public purse, and that's something which, because you're giving a fixed amount of premium per beneficiary family that needs to be covered, you know what your payout in a year will be, and therefore you can contain your budget, and there are no surprises. Whereas if you went through a trust model, and if there is high offtake of the scheme, there are more claims, there are higher value claims, all of that needs to be paid. And, you know, in terms of if your estimates of what it's going to cost in a year goes off, then you would have to get supplemental budget. So that is the risk that you have of the, you know, in terms of going through the trust model. But the way, because this is public money, you know, there are clauses in these contracts usually where if the you know, in terms of depending on what the claims ratio is, if there are profits which the insurance company makes, you know, the state does not let them keep the profits, and you have to share them back within the scheme. Similarly, there is also a loss sharing clause. If the insurance company's claims pile up and go beyond 110% of what they have, the money that they have received, then you know, the states tend to share that loss also. So in a way that sort of you know, blunts the whole use of the insurance as a mechanism. But what really happens is, in terms of insurance, are better staffed to do claims management as compared to the trusts that are there, which may be specially set up to implement the scheme. And they do tend, you know, whether we look at insurance or whether we look at trusts, they do tend to utilize the services of a third-party administrator that's there. And with trust, there is greater, you know, vulnerability of collusion happening between hospitals, and the possibility of that, and the trust and the staff is there. So that's one risk that one runs. But however, given, you know, for example, in PMJ, a trust mode has helped, because, you know, when you are evolving a scheme and you have to make mid-course corrections and change various elements of it, then what also happens is, in terms of trust, it's far easier to do, because in the case of insurance model, what tends to happen is that you already have a contract until the policy cover ends at a year for which you know, you've agreed on a fixed premium. It becomes more difficult to change things. Sorry. I'm sorry. Can I go back, Mona? Mona, can I share the screen? So I think I want to go forward. So in terms of the benefit package, so can you see the slide on the benefit package?
Yes, we can.
Okay. So in terms of benefit packages, this is where, you know, it's really a case-based payment that is rolled out. And there are, you know, when the scheme started 2 years back, there were about 1,393 packages, a combination of surgical and medical packages. And since this is about hospitalization care, and I know that we are really talking to the TB community here, and you'll say what's covered in terms of TB packages, essentially whatever is provided under the DOTS program, that's not covered, OPD is not covered. It's really hospitalization care, and packages that are included look at in terms of, you know, like pneumonia, meningitis, you know, tuberculoma, lung abscess, chronic cough, etc., that require hospitalization related care. But in terms of the whole presentation, I think what you can take away from here is, if you're looking at strategic purchasing for TB, some of the principles remain the same, and that's where I think some of these learnings would be helpful. And in terms of development of these benefit packages, this is really a long drawn process. You know, when the first set of the packages were developed, this was led by the Director General of Health Services, and they looked at the various state level schemes that were currently prevalent with, and providing government sponsored health insurance schemes. They looked at those packages. There were few costing studies that were available. And then there were specialty wise expert groups that were formed, which looked at both in terms of what services need to be bundled under a package, which would include everything, right from the consultation, the hospitalization related costs, the drugs, both pre and post treatment drugs, the food costs, in terms of all consumables, diagnostics, everything gets bundled under that. And this is something which, I think Owen shared how politically charged the pricing of these packages is. And the premier think tank, Niti Aayog, actually looked at the recommendations of this group. And there was, in terms of triangulation of the rates of these packages that was done with rapid household surveys, with rapid hospital surveys, with budget utilization of different insurance companies, the data that they shared, etc. But it wasn't, even though this was a long drawn out process, and just as the scheme was being implemented, looking at the offtake of the scheme and the feedback from the private providers in terms of really joining the scheme, there was, clear that the health benefit package needed to be in terms of rationalized because of there were inconsistencies. Also, there was a lot of, price control orders that were coming in terms of various implants, whether it was stents, etc. And there was this whole idea that instead of really bundling all the costs under the benefit package, perhaps the implant costs should be taken separately, because, when you have different implants that may be provided, because hospitals were providing a cheaper implant, and when these costs were bundled together, they were, providing a cheaper implant and charging for the more expensive one. So to take out some of those things, it was felt that the whole package needs to be looked at again. And this time around, really the National Health Authority, which is the nodal agency for implementation of the scheme, and the Indian Council of Medical Research together looked at the revision of these benefit packages and constituted about 24 specialist committees. There was much wider stakeholder consultation, and each of these committees had representation both from public and private hospitals, some of the centers of excellence, like the All India Institute of Medical Sciences, in terms of Tata Memorial Hospitals, etc. And also the whole host of industry association members were present in this committee, so that there was much greater buy-in that was there. In terms of the private provider network, in terms of, as I had mentioned, that nearly half the providers are private hospitals that were enrolled. What was really interesting is that up till now, we see that the vast majority of private hospitals are concentrated in about 7 to 8 states. These are states which already had experience of the schemes, and before PMJ came in and had a lot of experience with this, are where we had the hospitals. These are not evenly spread. And I think I will come to one of the issues related to that. The private hospitals tend to focus on provision of more specialized care. They tend to provide surgical specialties and super specialties and tertiary care tertiary care. One can argue that they really do what they are best at doing. That's one way of looking at it. The other way of looking at it, that they could be doing cherry picking in terms of benefit packages where they see that the rates are much more conducive and their higher value packages is what they tend to provide. So that's something which one needs to constantly review and look at. Overall, there's a lot of feedback from private hospitals which complain about low package rates. Some of it is more in terms of expectations of what they'd like to charge patients, what they charge patients that come to them who pay out of pocket. And some of it may be actually that the packages rates may be lower and the package may not be as viable as they ought to be. But one thing is very clear, given that in these hospitals, about 60 to 70% of the capacities to which they run. So PMJ does help them to meet with the excess beds. So if we look at the marginal value that they get from getting PMJ patients, that's something which is really very, very clear. Based on the analysis of how these hospitals are spread, etc., I think there are much more focused efforts from PMJ that are going on to look at improving the supply in poor performing districts where there's lesser utilization. Aspirational districts are also a combination of districts where the supply is less, the utilization is less. Also looking at 4 of the states which are not participating states in the scheme, like Delhi and West Bengal and Telangana, where, given that the scheme is a beneficiary could access services anywhere in India. So I could be from Uttar Pradesh, but if I am in Telangana, I should be able to take advantage of this. So to ensure portability of the services in non-participating states, NHA has empaneled hospitals directly. There's also a thing that, in terms of making sure that there are large multi-speciality corporate hospitals that are there. One, it improves the, in terms of the capacity of the scheme, as well as I think the whole, in terms of how, when you have large corporate hospitals like the Apollos and the Maxes where people can access services, I think the value of that also goes. So that's how, in terms of the augmenting of the network's been happening. Now, what I like to share is in terms of how financial incentives are really looked at in terms of driving quality. So there are 3 levels of hospital certifications that are there: bronze, silver, and gold. And this is something which, in partnership with Quality Council of India, the hospitals go through a self-certification process, which is then validated by QCI. And here what really happens is that if you get our silver certified hospital, which is an equivalent to a NABH entry level classification, you get 10% of extra benefit package rate. And if you are gold certified, then you get 15% extra benefit rate. This also, in terms of the way this also works, is in terms of it gets higher value, in terms of looking at beneficiary feedback of the hospital and their experience. Also, there are incentives that are provided. Then there is a whole system of medical audits that has been established, and I won't get into all the details of this, but in terms of what it has, the medical audits are conducted with in terms of both with the objective of fraud detection as well as provision of better and safer services to the beneficiaries. And through the medical audits, I think there are many things that have been addressed which look at in terms of whether all the critical documents are available to access the quality of service or not. If there is upcoding, OPD is pushed to IPD. There are mismatches between the utilization of the packages. There is, in terms of extended length of stay, that is there. And what has been done here, and I won't get into all the details of this, it's really a whole host of IT-enabled systems have been deployed, which actually look at how at various levels, whether we look at the levels of the SHAs or at the level of NHA, there are prescribed proportion of audits that need to be done. And this is not left to the team that is doing the audit. These are really driven by systems based on various triggers. And that's how these audits are done. And based on these audits, you have hospital risk scores that are developed. Similarly, there is a very sophisticated system for fraud control that has been put in place. And in fact, PMJ has a globally renowned advanced analytic solution provider. There is a comprehensive fraud analytics control and tracking system that has been put, which actually also helps in terms of look at a whole risk assessment and detection report that is developed And for hospitals in real time, it can actually monitor the patients that are coming in, what packages are being provided, and different kinds of analyses are being conducted, looking at analysis to risk profiling, and looking at, in terms of the genuineness of the patient, looking at facial landmark detection, in terms of fraud trend analysis, etc. Also in terms of, if you're detecting all of it and you don't take action, then you're not really going to have any kind of deterrence. And I think there are deterrence measures put in place as well. In terms of accountability, there are, very well established systems that have been put in place. There is a robot IT system which looks at the real-time flow of data, whether it's beneficiaries or transaction management or hospital empanelment. There are grievance redressal mechanisms that have been established, toll-free call center numbers which do both receive calls as well as do outbound calls. There are mobile applications through which you can get information, seek your grievances, both for beneficiaries and hospitals. After patients are discharged, they are sent SMS messages and tracked in terms of what's happening. And there's a lot of, in terms of monitoring and evaluation that happens. I know that in the interest of time, I did have, in terms of PMJ response to COVID, essentially they did, PMJ already has COVID-19 packages that are available, like the SARI packages that are available, which have been made available for COVID-19 treatment. And also there have been testing packages that have been developed. A lot of, in terms of the COVID-19 response, the states have been provided the flexibility to develop their own packages, look at testing packages, look at transportation of samples that were needed to testing labs, there are packages for that, packages for PPE kits, etc. That's there. Also to meet surge capacity, the response has been to be able to get private hospitals for a period of 3 months, fast track their empanelment. And what has also happened is, in terms of PMJ's call center has been merged with the National COVID Helpline and integrated with that. And through that, there is a lot of, triaging of data that's happening. Also, in terms of calls to follow up on the COVID patients that is happening. In addition to that, high-risk PMJ beneficiaries are also being made outbound calls so that they can be, there is a lot of discussion on what happens in terms of, providing them with precautionary messages. In terms of few takeaways that I wanted to share were, whenever you look at strategic purchasing, and this is something which you can look at in terms of TB, there is national and state level capacity which is needed for oversight and management of the state health agencies as well as insurance companies. In terms of strategic purchasing, though as a stopgap, one may be using TPAs. Ultimately, this is something in the long run for sustainability of the scheme. This is something which needs to be developed in-house. And we have good example of SAST, which is a SHA from Karnataka, which started with insurance companies and now has over 1,000 employees that look at the different functions. In terms of benefit packages, I think the importance is to understand that this is not you do it once and you forget about it. This is an ongoing process. And for this to be evidence-based, I think one has to look at disease burden, one has to look at actuarial analyses, costing studies, market pricing studies, etc. need to be incorporated so that they become more evidence-based. Last 2 points that I'd like to make is, one, in terms of a robust IT system is really the backbone, whether we look at empanelment, claims management, or fraud detection. The other aspect that I do want to mention, and I've already talked about fraud and beneficiary empowerment, so I won't go into here, but I think if the whole purpose, and going back to Owen's slide, is for expanding supply, it is really critical to see that when we engage private sector, are we actually doing that? Because otherwise, what's really happening is notionally we are providing this coverage to the people, but if they don't have facilities to go to, so we do have to look at that they may be in terms of distribution, in terms of geographies, in terms of availability of specialities, etc. If there are services that are not available, that's the place where the government systems really not functioning, that we do bring in the private sector. With that, I'd like to thank and turn it back to Ronald.
Thank you, Sheena, for that very powerful presentation. From the facilitator, Petra, she's proposing that we add another 10-15 minutes so that we wrap this up in about 10-15 minutes. So Petra and the other colleagues, I hope this is fine with you. And so we basically will switch to a moderated discussion. And our colleague, Guy Stalworthy, many of you know him. He's one of the leading voices and one of the leading technical authorities on private sector engagement in TB. I benefited immensely working with him. He's a global lead for private provider engagement at the Gates Foundation. So Guy, why don't you take over and basically facilitate for the next 10-15 minutes in this moderated session. And I hope, colleagues, you can stay for a few more minutes. We know this was a lot of content, but we just felt it was worth it to allow the speakers to take you through the technical content. So over to you, Guy.
Thank you, Ronald. This was extremely rich. We had many questions posted, and thanks to Owen in particular for responding already to some of them online. And this Q&A will continue online, and Petra will explain how we will have access to responses to all the questions. So if we don't get to all of your questions in the next few minutes, apologies for that, but there are alternative solutions. I'm going to just pick a couple of salient questions for the panelists. Commenting specifically about TB, I think the China and India examples illustrated the challenge in moving from hospital-based and hospital-focused care in these strategic purchasing arrangements to outpatient, connected outpatient care that is it's important for TB in the vast majority of cases. Can you comment more on the prospects of shifting to more of an outpatient-based system in India, Sheena, and any lessons from the efforts in China to shift TB care from hospitals to private to primary care that may be useful for countries like Indonesia and India facing the same challenge? As brief as you can be, I apologize.
Yeah. Thanks, Kai. So in terms of Ayushman Bharat, there are two pillars to that. One is looking at health and wellness centers, which really address the outpatient care element of this. And then the hospitalization part is the PMJ. And I think what one's currently looking at is in terms of currently they seem to be working as two vertical programs under the umbrella Ayushman Bharat. So I think the focus that needs to be there is how do you really develop the linkages between the health and wellness centers, which provide the comprehensive primary care, and looking at ways in which you have both forward and backward linkages with the PMJ. So that's currently where one is. There is some appetite to look at some pilots where primary healthcare can be incorporated, but this is something which I think we are still looking at, something in the future where this would be looked at.
Thank you, Dee. Any major lessons you can share from China to India and Indonesia and others who are tackling this problem?
Yeah, I think actually the shift has been kind of difficult in China, and I think mostly for two reasons. First is that it's kind of decided that we want a hospital-centric system in the way that the outpatient care will happen in a specialist outpatient clinic to get some economy of scale. Otherwise, if there are too many primary care centers or clinics, each taking like 1 or 2 TB patients, it's very hard to manage in terms of reporting, but and also kind of standardize the quality of care to distribute the free medicines, etc. So it's decided that it's going to be centralized in 1 hospital per county. And in terms of the kind of the emphasis on inpatient care, that kind of have a historical reason, because the social health insurance program is focusing on inpatient care, and there has been a lot of efforts trying to persuade them to add some outpatient packages for TB, but it's actually a lot of work in terms of having the IT infrastructure, the mechanism. So it actually waited until the social health insurance program really started some of the outpatient packages for NCD, and then TB was added as a special package to make it easy. And also from the hospital perspective, many of the hospitals, they don't have very good IT system for outpatient care. Most of the time, they don't even record the name in the earlier days. They just generate a one-time bill. So it's very hard for them to send the information to the insurance and to record, oh, this is a TB patient. So because of this house IT issues, it's also very difficult to cover the outpatient part.
Thank you. It's clearly, thank you very much. It's clearly challenging. I think maybe the last question for all the panelists. This is the capacities, the system, the technical skills needed to do good strategic purchasing. Owen, you talked about tools in 7 different categories. There's clearly many different skills and capacities need to be developed. What has been the bank's experience in sequencing of these capacities? How does an external partner like the bank help a country develop these capacities if they want to move in this direction? Or does it just all have to happen at once somehow?
I can take a first stab at that question, Guy. I think it's a very important one, and I think it goes to the heart of one of the core challenges of strategic purchasing, which is that it's more difficult than passive purchasing. If you want to go easy, want an easy way of doing things, then passive purchasing is the way to go. But in terms of sequencing, I think it's a matter of starting small. If the question is, let's say, private sector contracting, some countries start with non-clinical services. So they start, if they've never done any contracting before, they contract the laundry or the food or the gardening at the hospital. Then they move into maybe auxiliary services like laboratory services, and where it's a bit more of a sort of a standardized sort of product, so to speak. And then maybe get into some of the more difficult areas of contracting. If the question is benefit package definition, some countries will start just at one level of care or one sort of family of services. Maybe they'll just start with reproductive health at the primary care level and define a package there, and then slowly expand it. Clinical protocols, you can start with some clinical protocols and then add more and more. No country goes from 0 to 500 overnight. So I think it's really a matter of sort of scaling up. But I think this agenda of being very conscious of capacity constraints is a very important one. And I think sometimes it's overlooked. Countries see some of these tools like toys on the shelf or something, and they think, let's do everything and do it quickly. And then I think they get bogged down. So I think starting small, starting in some areas, some services, not everything, and then slowly building the capacities and learning along the way is really what's more likely to be a successful route.
And does anybody have any thoughts about how appropriate TB is as an early place for a country to start? It's highly countable. It's not so rare, but not so frequent. It really does require a lot of connection of services, ideally in outpatient. I'm sure there are other features, and one of the questions was, what kinds of services lend themselves more to this than others? How does TB fit into that, do you think?
I might punt that one to our TB experts, Dee or Ronald.
Dee, do you want to take that, or you want me to do it?
Oh, go ahead, Ronald.
So I think, Guy, just a quick one, basically to say that I think that there are certain, I think, features of a TB program which sort of like makes it maybe a good sort of like starting point. For example, I think a clearly defined sort of like maybe sort of like management protocol or routine, and then secondly, I think sort of like a fairly sort of like decent engagement with some of the structures like NGOs that might actually allow some of the accountability mechanisms that maybe you'd not find in some routine programs. I think the only disadvantage I think for the TB program is that a lot of the debates, large big picture debates on health financing reforms, like shifting from the passive financing to active purchasing, they seem not to be as engaged as much as the TB program really should be. So that kind of like sort of also brings in a bit of a barrier in terms of how sort of like TB lends itself as a natural starting point for some of these reforms. Maybe I'll just stop there.
Thank you very much. I think that's an interesting place to stop. It's kind of a call to action to the TBPPM Learning Group to get more engaged in these discussions and these issues. On that note, I think I'll turn it back to Petra.
Thanks, everyone. This has been a really rich learning for everyone, I think, around in our full audience. Excellent presentations. Really appreciate all your input and your in-depth knowledge and your answers to all the difficult questions. Owen, thank you for answering them actively online already. Thanks to the audience for being engaged beforehand and during this webinar. Really appreciate it. And thank you for moderating, Ronald and Guy. Great job. So we are going to be posting this. Oh, Madhujit, you want to come in?
Yeah, just to thank all the panelists, but also to ask a question that if there is one thing I have learned by doing a large number of quality of care studies in multiple countries, is that quality of TB care is extraordinarily variable in the private health sector. That's the only guaranteed finding, right? It's a dramatic difference in quality of care. So the big practical consideration is, how do you then identify higher quality providers to contract with them? And how does one actually make it happen? Because you can't judge someone's quality that easily. And whether it's a small clinic, like outpatient clinic, it's even harder to identify or separate the higher quality providers from the lower quality. So that's a real practical challenge. And folks like Jishnu have been working on it for years to see if there are any simpler ways of identifying higher quality providers than lower quality. And then the other question, responding to Guy's comment, is TB is never seen as a profitable thing for any private provider. Drug-resistant TB, perhaps, but drug-sensitive TB, no, because it's outpatient care, the drugs are cheap, there is not a lot of money to be made. So that's partly why we struggle with having any amount of uptake by private providers, because they just don't see that as a relevant thing for their business. And I'm not quite sure fundamentally how or why that should be changed. And TB is also often seen as a government responsibility, right? So private providers think, oh, if it's TB, then it's not up to us, it's up to the government. How that will all change with this COVID and the need for more capacity to deal with respiratory infections, I don't quite know. But again, for COVID, it's the hospital care and ICU care and ventilators where private sector has been ready to jump in because they see an opportunity to make money by offering those high-end hospitalized care, not the outpatient type of care. Thank you.
Great points. I see that we're not done with this discussion at all, and I'm really pleased to see that we have a webinar series that is continuing this discussion. In fact, our next discussion is going to be on social health insurance, and many of the presenters posted information on this specifically. So we're really pleased to be able to offer another platform to continue the discussions and the important topics that we raised today. In our next webinar, we'll be talking with Vietnam, Indonesia, and the Philippines on their activities related to social health insurance. So definitely we will be taking forward the content that you have provided here. We will be posting this webinar on our site. We will be posting all the presentations as well. Thank you to all the presenters for making these available. We will also post the questions and answers that we have currently, and we will be asking the panelists to kindly provide some inputs on the last questions that we have got. These will be available to you shortly. In the next few days. You should be able to find everything online. Please follow us on, you are welcome to join the TBPPM Learning Network to take these discussions forwards, and we will be posting information on Twitter. I'm giving big smiles to all the panelists. I really appreciate you sharing your knowledge and your expertise with us today, and you've certainly brought up a lot of learning for the TBPPM Learning Network to continue chewing on, and we look forward to engaging with you in the future. Thanks very much to everyone, and wishing everyone a great day.
Thanks, everyone.
Thank you.
Thanks, Petra.
Thank you, Petra.
Thanks,
Thank you.
everyone.
Bye.
Bye-bye.